Welcome, everyone. Thanks for joining us today for this wonderful talk. Andy is going to talk about genetic gaps and good news, an update on Aboriginal cancer research. And I think this is a very fitting talk and very exciting, especially in context of the Reconciliation Week. And we're very excited to hear all from you. Thank you so much.
Thank you for that introduction. I have to say he's not yet seen the talk, so saying it's an excellent talk, I'm very excited. I'll try and live up to that. This is a very mature talk. I finished it at 3:30 this morning, though. So hopefully there aren't any accidental holy photos stuck in the middle. I apologize for that in advance. So today I gave a talk last year in Reconciliation Week, and we've done some more work since then, and I've also restructured the order of it to give it a different flavor about the journey of particularly Aboriginal people as they diagnosed with and then are treated for cancer. Let's find out which of my controls. Phew. Okay. So I've divided the journey into sort of four areas. I'm going to talk about two together at the end. So firstly, there's prevention, and that's obviously the ideal scene. We want to not get on that road at all. Then there's screening. So that's often confused with prevention. Screening isn't prevention, but it's preventing a lot of treatment and a lot of morbidity and mortality from cancer. And then there's where cancers are caught at an early stage, all being well, through screening increasingly frequently, and we have a chance at cure and optimizing that chance of getting rid of that cancer for good. And then we've got the scenario where either the cancer is at a later stage when it presents, or that the cancer has come back and we've failed to cure it, and then we're talking about controlling it and how long can we control it for. And this isn't something I talked about last time, but I'm going to talk about cancer prevention, and this is relevant to us all because we all want to prevent cancer in ourselves and people we know, and there are certain things that apply to us all, and I'm trying to adjust those sort of preventative factors as to how they apply to our Indigenous population. So how are we doing with cancer prevention as a start? There's a lot of exciting news headlines about potential cures for cancer, the latest thing for cancer, fighting cancer. You don't hear very much about in the newspapers about cancer prevention, and that's probably because you don't know when you've prevented a cancer in any one person. Nobody comes and says, thanks very much for preventing my cancer, doctor. They certainly come and say, thanks very much for curing my cancer. And so prevention tends to sort of be less glamorous and take a back seat, and only about 4% of all health research dollars in Australia go towards prevention. 96% goes to biology, treatment, survivorship, and so on in cancer. And as you can see from this graph, prevention is not going all that great. This is when I started medical school over here, and then these are projections, though these have now been realised, showing that cancer cases in Australia have gone up every year. The blue line is, because the population's grown and has aged, the blue line is a compensated cases per 100,000 of the population adjusted for age, and that also has gone up by about 20% over that time. So cancer cases in real terms are increasing. In terms of the Aboriginal population, what are the core, where should we be focusing our efforts when we think about prevention? And this is the most common cancer types in Aboriginal people, as per the last report, which was in 2019. We should be doing another report, I think, fairly shortly. As you see, lung cancer is the most common cancer in Aboriginal people, followed by breast cancer, even though breast cancer is confined to ladies. Or largely anyways, occasional gentlemen, colorectal cancer, prostate cancer, and then head and neck cancer. And we've looked at, in a reasonable amount of detail, at 3 of these, and we're just coming towards bowel cancer at the moment. And I'll show you some of the things that we've found out regarding the types of cancer, the stages, and how treatment goes with those cancers. In terms of the prevention in Aboriginal people, Katie and Lisa, who are in the audience, front and centre, myself, were fortunate to be involved with Sandy Thompson's group, Andrew Guyan, Lenny Papertalk, Melanie Robinson, and Alex Brown, who is ubiquitous across Aboriginal cancer research and a powerhouse of that, looking at preventative factors and risk factors for Aboriginal people, from which I learned a lot. And the risk factors that kind of pertain to Aboriginal people that I'm going to talk about. Firstly, we've got inherited mutations. So people, when they think about cancer risk, they often think about this area that you carry something in your family that gives you a risk of cancer. And when we did a sort of a back of envelope interview process with our patients with breast cancer, and 42% of people thought they might have a gene to help explain their breast cancer, whereas actually when we get down to genes that we know are involved, it's 5%. So way more people think there's a genetic cause of their cancer than there are. But in those people that do have an inherited gene, the cancer risks are very high. It can be up to 80% for breast cancer and 50% for ovarian cancer in some populations. And so it's very good to find these smaller numbers of people. What about Aboriginal people? Well, in this review, the conclusion was that there is no literature at all on looking at the specifics of inherited mutations in Aboriginal people. We have, however, just submitted a paper on that, which I'll show you in a minute. Next one is breast density. This is a bit of an unusual single factor. This is looking at the density of a mammogram when a woman has a mammogram. Can't be done in men, even though they can have a small risk of breast cancer, particularly with inherited mutations. Is a female mammogram, and it's how white the mammogram looks. Well, it's a fairly crude estimate, but it's a very important risk factor for breast cancer. And we're doing a bit of work looking at tissue density in other tissues to see if we can predict other cancers, or we've been about to start for some time, starting with pancreatic cancer. Can we look at pancreatic density and predict pancreatic cancer? As it's been so useful in breast cancer. Next, infections. There are a number of infections, and some of these are more prevalent in the Aboriginal population, which give you a risk of cancer. And then we're getting into the lifestyle stuff. There's the quality and quantity of food, weight and diet. There's exercise, and then tobacco and alcohol, which I'll talk a little bit about as well. I won't actually talk about alcohol, but just to mention it, looking at alcohol in the Aboriginal population, there's a common concept that Aboriginal people drink significantly more, and there is significantly more alcohol-related disease. And certainly speaking to Aboriginal collaborators, they've had that sense also, but that isn't actually the case. When you look at alcohol-related medical factors and disease in Aboriginal people, there's more people with injuries in the younger population, and social disputes and so on related to alcohol. But actually, when you look at alcohol disease, it's actually more common in the non-Indigenous population. So it's more white guys like me sitting at home drinking way too much that kill off our livers, and that's rarer in Aboriginal people. So there's not a bigger burden of disease in Aboriginal people. So I won't talk about alcohol again, but I'll come back to smoking. So going to the risk genetics in Aboriginal people, and firstly, breast cancer genetics. This is a little pie chart of some of the common genes that have been found. If they're mutated in certain areas or altered in certain areas within families, you've got a high risk of breast cancer, and ovarian cancer often goes hand in hand with that. And the two common ones we know about are BRCA1 and 2. Most people have heard of those. Angelina Jolie famously found that she carried BRCA1 gene, had double mastectomies, and certainly the Familial Genetics Service in WA decided they should probably put on an extra phone line when they realised this was in the press. One phone line was not enough. They had all kinds of people who'd had very distant relatives of breast cancer phoning up. In terms of the Aboriginal population, until recently there was no information, but we just submitted this for publication. We've looked at the Aboriginal population in WA from 2001 to 2016. I'll talk a little bit more about that cohort shortly. And looked at how many people were tested for risk genes, how many people were positive, what for. We saw that Aboriginal people were offered genetic testing about 90% as often, and they accepted that testing about 90% as often, so very little difference there. But when we actually look at the results of those tests, the bars nearest to me, the orange bar is the number of positive tests per 1,000 people tested in the non-Aboriginal population compared to the Aboriginal population. We see that there's about fourfold less positive tests in the Aboriginal population. And when we look at the number of actual confirmed genetic cases in the breast cancer population, it's sixfold less. So it doesn't, this is therefore is compensated for testing. So it seems that there is genuinely a very low rate of mutations in the Aboriginal population for the genes we know about that really come from studying European populations. BRCA1, for example, we saw 0 cases in the whole last 2 decades, essentially. And we saw a couple of BRCA2 cases and none of the other rarer mutations either. For bowel cancer, the other cancer that's commonly screened for genetic mutations and risk. And the common one that we look for here is Lynch syndrome. It carries about 3% of the bowel cancer population, but if you've got that gene, your chance of getting bowel cancer about 50–60%. And there is no data on Lynch syndrome or other genes that give risk for bowel cancer in the Aboriginal population. We do, however, have funding from the Cancer Council for this grant. And so we're going to be looking at how many people have been tested in the last decade and a half in WA to see if we get an idea of that. So moving from genetic risk factors, that when I talked about breast density, this is 3 mammograms. Moving from your left to your right, we go to low density, medium density, and high density breast. This is normal breast tissue. This isn't cancer on the mammogram. And you see the risk of breast cancer relatively. It's a relative risk of 1 here. It goes up 500% if you've got dense breasts compared to low density breasts. And that probably equates to about a 5 versus 25% lifetime risk of breast cancer. And we did some work 2 or 3 years ago with Jennifer Stone, who's an international sort of queen of breast density, looking at the Aboriginal population in breast screen here compared to the non-Aboriginal population. And we saw that breast density in Aboriginal women was significantly lower on average than in the non-Aboriginal population. So the number of people who have very low density breasts in the top sort of less than 10% white tissue on the breast was over 50% compared to only about 20% in the non-Aboriginal population. And that one would predict would lead to a lower risk of breast cancer, and also it can impact on better treatment also and better screening. So both the lower genetics and the lower breast density in the Indigenous population suggest we might see a lower rate of breast cancer occurring. And that's indeed what we did see. This is 2001 to 2010 in WA. Because there are low numbers of cases of Aboriginal women getting breast cancer, the line is a little bit jerky, but overall it was 1/3 less cases in Aboriginal people. And that's been found in Northern Territory and in New South Wales also. It may be due to these lower genetic risk factors and also breast density being lower. Turning to weight and diet, I won't review the entire literature for you, because that will be the rest of the talk, but talk about what we've observed ourselves. We do have the BMI, so the weight over height ratios for our population of breast cancer patients across a couple of decades in WA. And this is women in that group in the ideal weight range, and this is the overweight or obese range. The red bars are the Indigenous patients and the blue bars are the non-Indigenous patients. And we actually saw no significant difference, but as you see, about 3/4 of people were overweight or obese. And that in fact is reflected in the general population. In 1985 in WA, 8% of people were obese, and it's now 33%. And that likely contributes quite a bit to that curve of cancers going upwards that we saw right at the beginning. And the kind of cancer that you can get with obesity, breast cancer, bowel cancer, esophageal cancer, which tends to be thought of as smoking and alcohol-related one, but obesity puts your risk of that up 3-fold. Kidney cancer and endometrial cancer got the highest risk, about 4 times higher if you're obese. But we say, to emphasize, we did not see a difference between the Aboriginal patients and the non-Aboriginal patients, but we saw there was a significant problem to be addressed across the whole population. Now, there's a lot written and taken around the town of people who've had cancer, want to prevent cancer regarding vitamins. Really the only one that's got solid information on some degree of prevention or association with outcomes is vitamin D, though a lot of it still remains associated. Higher vitamin D tends to be associated with lower cancer risk and better outcomes. And papers have tended to try to compensate for other factors that might go alongside a high vitamin D level. And certainly but we did see in the vitamin D deficiency was much more common in our Aboriginal population. It was twice as likely, almost half of the Aboriginal breast cancer population were vitamin D deficient, compared to about 1/4 of the non-Aboriginal population. And this may relate to darker skin, as vitamin D is made by the action of UV light from sun on cholesterol and skin, turning it into precursor vitamin D, as well as it might be also dietary aspects. The other thing that we hopefully will look at in due course as we get more prospectively into the community is things like exercise and dietary components. There's certainly a lower input of lower intake of vegetables in some remote Aboriginal communities, and that's partly because of supply. And it can cost over $10 for a lettuce compared to even IGA, which is a little bit pricey, is like $3 near me at the moment. So when you've got to pay 3 times as much for your vegetables, whereas McDonald's is the same price. And provided you don't take out the gherkin, you're okay probably, but there's a very substantial cost to being healthy, unfortunately, and especially in remote areas. Turning to tobacco, there is a higher rate of smoking in the Aboriginal population, particularly younger Aboriginal people, though it is falling along with the rest of Australia's population. Australia is one of the poster countries of smoking prevention. Not quite as good as Sweden and New Zealand, though they're approaching the 5% or less of smokers, which is called a smoke-free country. I think the difference they've had is they've promoted vaping rather than promoted healthy supply of vaping products, which has got nicotine but no tar in it, and that's helped with their smoking cessation and also the lung cancer risk, whereas we here tend to advertise against smoking and vaping, and there's quite a debate around the vaping question. One of the problems with vaping is you start buying off the internet to every small site abroad, you don't know quite what you're smoking, and so there probably a lot of the risks lie there. Tobacco in our populations we've observed, we've certainly seen when we look at the 2 cancers we've studied, lung and head and neck cancer, that a greater proportion of the Aboriginal population were either active or previous smokers. This is lung cancer. And the black segment of the pie chart is the smokers. The grey part is the ex-smokers, and the white is the non-smokers. The Aboriginal lung cancer population we've studied, 97% were current or ex-smokers, so only 3% non-smokers compared to about 17% of non-smokers in the non-Aboriginal population. One thing to bear in mind about this, we tend to go, oh, that's lots more Aboriginal people smoking, so that's why there's only a very small white part to the lung cancer spectrum, but Aboriginal people are actually getting something like 6-fold, therefore less non-smoking related cancers, and this does suggest that they may be less prone to cancer in non-smokers, or there may be environmental factors such as air pollution and so on that they're being less exposed to, and so it may not all be that it's just that there's a lot more smokers, as it's a moderate number more. It may be they're actually less prone to getting those non-smoking related tumours. Head and neck cancer, again, head and neck cancer can be driven by tobacco. It can also be driven by human papillomavirus, certain types. And looking at the samples, the head and neck cancer samples in Western Australian Aboriginal and non-Aboriginal people, we saw about half of the non-Aboriginal population had evidence of HPV infection compared to only about a quarter of Aboriginal people, and a high smoking rate. So it does appear that smoking is a bigger driver there also. And certainly, therefore, smoking cessation is very important. Finally, infections, and there's a number of infections that can increase your risk of cancer. First up, hepatitis B, depending on which area you look at, can be up to 10-fold more prevalent in the Aboriginal population than the non-Aboriginal population, as high as endemic areas such as China and Hong Kong. And this gives a significantly higher rate of hepatocellular carcinoma, which is about 3-fold higher in our Aboriginal population. There is screening, though, for with ultrasound and alpha-fetoprotein if you have chronic hepatitis B. It's certainly recommended, and there's a push to get that into the Aboriginal communities as well. And there is a vaccination, and that is delivered in a more frequent and earlier age in the young Aboriginal people than in non-Aboriginal people, to try and address that risk. Certainly the carriage rate is dropping in Aboriginal people. We haven't yet seen much of a shift in the liver cancer rate, but that does take some time, as the cirrhosis damage takes some time to cause the cancer, and we hope to see it drop in the near future. Helicobacter pylori, this is the funny spiral-shaped bacteria that you can grow in your stomach, discovered in Perth, obviously, very famously, with Robin Warren drinking solutions of Helicobacter pylori, getting stomach inflammation, and then curing himself with antibiotics. And I was in 1985, there was a gastroenterology registrar who'd just gone to a conference in America, and he'd seen Barry Marshall present, and he said nobody else believed it. There was uproar in the room, everybody shouting at him and saying this is nonsense. But he said it seemed really like he'd done good work, and we started treating it back then in Aberdeen, and it turned out he was right. It probably saved millions of lives. If you eradicate Helicobacter pylori, Helicobacter doubles your rate of stomach cancer, and if you eradicate it, you see a halving of your stomach cancer risk. And the Aboriginal population have 2 to 3 times the frequency of Helicobacter pylori infestation, but it's a simple 10-day course of antibiotics and acid blockers to get rid of it. So certainly testing and eradicating is should bear significant fruit. Other one for HPV, along with head and neck cancer, is cervical cancer. HPV 14 and 16 we now vaccinate against, and the program's been going since the early 2000s, and in Aboriginal young Aboriginal people there's been testing now, and the risk virus rate has dropped from 24% carriage to 1% in the Aboriginal population. And so again, it's one where it takes a little while to see the benefits of in cervical cancer, as people are already infected. Vaccination doesn't eradicate the virus, but we hope over the next decade or so to see a further drop, and there's been an early drop already. Finally, Epstein-Barr virus, coming back to head and neck cancer. This is a very common virus. Certain variants of it increase the risk of nasopharyngeal carcinoma, and that's seen. We see high rates of nasopharyngeal carcinoma in Aboriginal people, and there are other cancers such as non-Hodgkin's lymphoma also linked, and we see a higher rate also of that tumour in Aboriginal people, and potentially somewhat higher lying fruit eradicating HPV of certain subtypes might be beneficial. So that's sort of some of the things you can do, and one of the things say that's the less glamorous thing preventing cancer. You don't tend to, nobody buys you a box of chocolates or a bottle of wine for preventing their cancer on the whole. I've observed, even though we give out a bit of preventative advice, but the question is, whose job is it anyway? And it's really, is it an oncologist's job? And my job is to kind of try and cure cancer or control it. And it's too late by the time people come to me, obviously, though I do, when I see risk factors, try and adjust those so people won't get another cancer. And it's a little bit heartbreaking if you cure somebody's lung cancer and they keep smoking and get a head and neck cancer or something like that. We see that not infrequently. General practitioners, obviously, in terms of being at the forefront of health, are the people in the place where they can take action, though they've got a lot on their plate. So, we probably need more resources and more education and so on for general practitioners to help incept some of these things to bring that cancer rate that started on the way down. Also, in the Aboriginal population, there's probably almost better information than the non-Aboriginal population. We're seeing some nice materials on prevention. It'd be good to see that filter through to helping orientate people to cancer treatment where there isn't such good data. But this is just some examples of posters. And certainly research suggests that if there's more graphic illustration, less writing, then Aboriginal people gain a better understanding, prefer that information. I've got to say, when I talk to my own patients and non-Aboriginal, that's absolutely the same as well. So we need to take the lessons from what we're discovering here, and materials for Aboriginal people and probably expand it more widely. So that's prevention. Turning more briefly to screening, as there's a vast amount about prevention. Screening is, there are certain cancers that can be screened for. And the main two that are screened, or three that are screened for cervical cancer, which we don't have data on, breast cancer, bowel cancer, and lung cancer is about to start. So in terms of cancer screening, where do we sit with the Aboriginal population? Mammograms, for a start off. Leanne Pilkington, who's been my long-term collaborator since 2008, I think, so we've been working on Aboriginal cancer for 17 years together. And she's given me almost all the knowledge I have in the subject from the cultural and some of it medical perspective as well. And she worked at Breast Green for around a decade trying to get screening rates up. And there was a lift across her tenure of about 10 to 15% in breast cancer screening rates in the Aboriginal population. And there has been a lift also in the general population. And the dark blue line here is the Aboriginal screening rate, though, and the light blue line is the non-Aboriginal screening rate. So we're still seeing about a 12% difference, and we'd like to increase that. This is a remote does have an impact on that as well. And one of the things Leanne's taught me is you don't want the mammogram van, to arrive at appropriate times in an Aboriginal community. Many Aboriginal communities will have a social administrative structure where there are times set aside by the elders for men's business and women's business. If your mammogram van turns up during men's business time, then you're not going to get many mammograms done. And so that kind of cultural administrative knowledge is very important. Mammogram participation is low, but as we've already seen, breast density is a good bit lower in Aboriginal population. That makes their breast cancer risk low, but it also makes a mammogram a better tool to pick up breast cancer. In fact, when we look at detection rates in high and low density breasts, this is if you have low density breasts, 92% detection rate for cancer compared to only 60 if you have high density breasts. So chances of a mammogram missing a cancer in an Aboriginal lady are significantly smaller, about half what they are in a non-Aboriginal lady. And so if we can get the screening rate up, we're likely to get bigger rewards than increasing it in the non-Aboriginal population. What about bowel cancer screening? Well, this is the latest national report from last year compared to 5 years before that. Rates were lower in the Aboriginal population, but they appear to have been successfully addressed quite significantly. The gap has dropped from about 20%, a halving from about 40 versus 20%, up to about 40 versus 35%. And so there's been a significant closing of that gap. I couldn't find any literature on what's led to that other than there has been a lot of educational materials and community efforts. One of the things we learned from collaborators in, the Broome Medical Service, and we've spoken to them, and they pointed out that they test many people in their community for bowel cancer with the bowel cancer screen. The bowel cancer screening involves taking a poo sample and putting it in your fridge if you have one, and then posting it when you've got 2 samples. And in 50 degrees, and maybe if you haven't got the best fridge in the world, that affects their results. And so they actually do screening within their general practice community, and that doesn't appear in bowel cancer screening. So they say the gaps that appear, you have to be wary of, because some people are getting screening via alternative routes. When Aboriginal people are screened, then there are more higher positive fecal occult blood tests, and a need for more colonoscopies, therefore, to look at bowel cancer. And they do find that for positive tests, there are less people referred for that testing, and there is a longer term time Aboriginal people wait until that testing occurs. And there are obviously things that we need to try and address. And we're going to try and look at barriers to screening locally as part of our bowel cancer project that's about to start. It's our 4th cancer we're studying. I also note that we probably need to speak to AIHW, which has this, the data you see here, but they have remoteness data, they have socioeconomic data, and they have Aboriginal status data, but they don't combine them. So there will doubtless be pockets of people who are remote and potentially Aboriginal, potentially of poor socioeconomic group that may have very low rates. And AIHW do have a facility where you can speak to them about different analyses of their data. Finally, lung cancer screening. Lung cancer, as we saw earlier, is the commonest cancer in Aboriginal people. So lung cancer screening will be a high priority there. And as we've also seen, the smoking is a big cause of lung cancer, and it's smokers that are part of screening programs internationally. So we'll be screening for the commonest cancer in a population that have a high rate of the main risk factor. And lung cancer screening is coming to WA in October this year, all being well. This is Annette McWilliams, who's a lung cancer screening lead, as well as a respiratory specialist at Fiona Stanley Hospital. And she's certainly got on her agenda to develop the screening program with Aboriginal people in mind also. And they've applied for 3 roving vans with CT scanners in them, and they've been offered 1, I think, so far. So she's wishing she'd asked for 9, then maybe she got the 3 she needs. But that'll be no doubt a work in progress. And this just shows you a couple of the cancers you can get with screening. This is a T2 cancer, 2 centimeters, greater than 80% cure rate with an operation. This is a T1 cancer, sorry, at the top, T3 cancer, 7 centimeters, and that's got a less than 20% cure. And often cancers can get to this size without people being particularly aware of them, particularly in smokers where there's a cough is pretty prevalent anyway. And so with lung cancer screening, it improves the survival by about 20% of people who get lung cancer. So moving from, we've looked at prevention, we've failed in prevention, we've now maybe successful in screening, maybe people haven't had screening, they have cancer. What about cure? How are the cure rates in Aboriginal people that get cancer? What are the factors that might impact those, and what can we do about them? And I'm also in the same area going to talk about control as well. Data, a lot of our data relates, some of it's relating to curative treatments to get rid of cancer, and then smaller amounts, particularly in lung cancer, are relating to controlling it, as cure is relatively rare. Now, there's been lots in the press. You don't see so much about prevention in the press. You see lots about curing cancer. This is a random assortment of articles about promise and hopes for cure and how results are all improving. So as the Aboriginal population benefited from that, and this is a sort of the reality check that unfortunately, no, this is the latest data from 2018 showing while there's been a 16% relative drop in death from cancer in people that are diagnosed with it in the non-Aboriginal population, there's been a 26% relative increase in the Aboriginal population. So despite all these new treatments that we read about and all the promise and all the improvements, Aboriginal people do not appear to be advantaging from them. This takes us to sort of the work that we started doing. And I've already talked about some of that as it pertains to prevention and screening, but and we looked at where the excess mortality was in Aboriginal people, looking at the most common cancers lead to Aboriginal persons' demise relative to non-Aboriginal people. This is deaths per annum in Australia and per head of population, and we see that head and neck cancer got the biggest gap with a 26% mortality. Then breast cancer an 18% extra deaths, colorectal cancer 15%, and then lung cancer 12%. So lung cancer, there's a substantial number of deaths, as you see, far more than any other cancer. And so we've looked at 3 of these cancers, breast, lung, and head and neck cancer in some detail, and we're just starting, as I mentioned, on bowel cancer. To say what is the population that we've been studying to look at the results of these cancers in Aboriginal people. Head and neck cancer, we've looked at the South Metro population. That's my health service, and but head and neck cancer is only really managed largely in North and South Metro. So that's about heading towards half of the treated population in WA. And we did that for reasons of administrative sort of sensibility, in that the application process to get data out of the Department of Health takes several years. Is that right, Katie? About right? Do I exaggerate? No, I don't exaggerate. We've noticed that getting data is slower and slower. And as we've gone, I think it took us, because what we're doing with breast cancer and applying to us about a year. I think with head and neck cancer, it took us 2 years, and with lung cancer, it would have taken us 3 years if we'd not taken innovative action. So bowel cancer, now we've managed to accelerate a bit, and we're through in about a year and a half. So for head and neck cancer, we looked at just half the population, just because we could get started straight away, but we were looking at the whole population just for comparison. The other 3 cancers, we looked at all Aboriginal people in WA that have self-identified as Aboriginal, diagnosed with those cancers as recorded in the cancer registry, which aims to record all cancers across the state. Different periods, 2001 to 2016 with breast cancer, 2010 to 22 with lung and bowel cancer. And our model is that we take all the Aboriginal people in the registry, and we match them by age and remoteness to non-Aboriginal people. So we end up with 2 or 3 times as many non-Aboriginal people. And you see the cohort sizes there. We've got about 320 head and neck cancer patients, about 1,000 breast cancer patients, lung cancer about 800, and bowel cancer we predict about 750. So what about mortality? What have we seen? And we certainly, this I showed last year as well, breast cancer mortality across the initial period was very high, with a 30% gap. So 10% of people dying by 8 years in the non-Aboriginal group, and 40% in the Aboriginal group. Head and neck cancer, a similar gap. The survival rates are generally lower, as it's a harder to cure cancer, but still 30% difference between the 2 populations. Lung cancer survival's not such a big gap, but the death rate from lung cancer is so high already that becomes almost a little bit moot. There's 2 flavors of lung cancer, if you will. There's a small cell lung cancer, which hard to cure with surgery, but responds well to chemotherapy. And we saw not much difference actually in small cell lung cancer compared to a published series. Non-small cell lung cancer, a commoner cancer, about 80% of lung cancer. And we saw in the advanced lung cancer only small disadvantages for Aboriginal people. But in the stage 1 cancers, there's one closest to me, the ones that you can potentially cure with an operation, we again saw a 20% gap there. So the most curable lung cancer in Aboriginal people, we've got a problem. We're going to look in detail at that. As there, the cancers also we're likely to find by staging. So it's important, by screening, sorry. So it's important if we find more of these stage 1 cancers that we've got our act together in terms of getting the best cure rates. So we've seen higher mortality, certainly head and neck and breast cancer, and in low low-stage lung cancers. And why is this? Firstly, is it cancers are bigger? Either they've grown faster or people are coming later. And that's certainly been true for the cancers we've looked at. Breast cancer, stage 1 cancers are small, no lymph nodes involved, the most curable cancers. Stage 4 are widespread cancers, very hard to cure, with getting bigger with more lymph nodes as we go down. We saw a migration of about 20% of people from the most curable stage 1. We saw a 20% migration with Aboriginal people having 20% less stage 1 cancers. And that 20% was really divided equally into thirds between stage 2, 3, and 4. Head and neck cancer, we saw having a bigger difference. We saw only 8% of Aboriginal people compared to 23, so threefold less had stage 1 head and neck cancers. And obviously that percentage has to go somewhere, and unfortunately it's all in the stage 4, not even the bigger cancers, but the already spread metastatic cancers. So obviously an important thing to look at is its delayed diagnosis. Are we seeing these things later? And are Aboriginal people coming later? Are there medical services being less diligent in testing and applying for treatment and so on? And we've looked at that in breast cancer and head and neck cancer. And a little bit, I guess, to our surprise, as we anticipated there might be a delay somewhere, we have not really seen that, bearing in mind that the non-Indigenous population we're studying here is very remote as well, or equally remote. So in breast cancer, we looked at people finding something and taking 3 months or longer, which is considered a reasonable time in which to think maybe this is something I should get checked out. We saw very little difference. About 3/4 of people at least have gone to their GP within 3 months in both groups. Taking 1 month for a GP to sort out a diagnosis with a biopsy was over 80% in both groups and very similar. And once you had a biopsy, getting to surgery again was 80% in both groups of people that had an operation within 1 month. So very few delays there. Head and neck cancer, similarly, we looked again at that 3 months from getting the first symptoms where things aren't quite right, seeing your GP. And again, very low rates of people were longer than 3 months. And the GPs or other practitioners looked pretty onto it as well. 2/3 of people had a diagnosis within a month, and this is a harder to diagnose cancer often than breast cancer. So it didn't seem to be delays. So what else could it be? And so we want to know then about treatment and about the types of cancer that people are getting. Are they getting worse cancers? And is treatment not being offered? Is it not being accepted? Or is treatment just not working as well? And there's a number of steps when you treat a cancer. It varies cancer to cancer. Surgery and radiotherapy have been studied quite a lot in the literature. It's often in big databases. It's pretty easy to get hold of. Operations are recorded, and radiotherapy usually have databases. It's a pretty significant treatment and well-recorded results. Drug treatments are much less well-recorded, so there's a lot less published on those. And it tends to be just how many people got a particular kind of treatment across a whole group. It didn't look at whether the people had what kinds of cancer within a type of cancer people had. But the other steps have really not been looked at, therefore. Chemotherapy, very little information. Targeted treatments, very little information. And immunotherapy, which is increasingly being given to people with cancer. And it's now estimated about 40% of people with advanced cancer will get immunotherapy at some time during their course. Very little data there as well. So starting sort of with the sort of chemotherapy part and radiotherapy, sort of going a little bit into radiotherapy first. Chemotherapy and radiotherapy are an important part of curing head and neck cancer. And obviously many people with head and neck cancer didn't have curable disease, but looking at the population that did, we want to know how many people refused treatment. This is probably the toughest treatment of any cancer locally, with weeks of radiotherapy, very severe side effects, unable to swallow and needing feeding tubes often, and things of this nature. And we saw that almost 1 in 5 Aboriginal people who had curable disease declined that treatment compared to a very small fraction of non-Aboriginal people. We looked at the barriers there and found that the kind of things you would expect, I think. Concerns over the major surgery. These operations are 8 hours, sometimes parts of the tongue or jaw removed and so on. We found there were concerns over chemoradiation. Again, significant side effects getting chemoradiation in that area. We found also people didn't want the concept of having feeding tubes put into the stomach through the tummy wall, having tracheostomies for periods of time. People preferred just to go home and live out their remaining life rather than go for these radical treatments. And then that concept of being away from home is certainly important as well, as you might expect. Looking at about probably 2 months off country away from home and family for head and neck cancer treatment. And that was a big barrier too. And that's obviously something we can try and address with better supportive facilities and facilities for people, for family to be able to stay with patients as they have these treatments. Looking to chemotherapy in breast cancer, quite a large rate of decline in chemotherapy for head and neck cancer, but usually goes with radiotherapy, and it's tough stuff. Breast cancer, it's more medium range chemotherapy. And we saw in terms of decline in chemotherapy, a smaller rate. About 8 out of 10 Aboriginal people accepted chemotherapy compared to 9 out of 10 non-Aboriginal people. I want to bear in mind as well, sometimes this chemotherapy has only got 2 or 3% survival advantage. We're not looking at cure versus non-cure like we are with head and neck cancer. So I offer some people chemotherapy. It's my duty if I feel there's some benefit to do so, but I might not even accept it for 2% benefit. And so within that, I think generally 80 to 90% is considered the reasonable range, but a slightly increased preference for not having chemotherapy in Aboriginal people. We saw a much bigger difference though when we came to what doctors gave. When we looked at the intensivity of chemotherapy, we saw that the most effective strength of chemotherapy, as we judged it in a case, was given less than half the time compared to 3/4 of the time in the non-Aboriginal patients. And we're looking into that, but generally doctors, we occasionally offer people 2 recipes, a moderate one or a stronger one, but that's not done all that frequently. And so we suspect that this is a bias in the medical specialists in offering Aboriginal people lighter treatments. We have to compensate for comorbidities, other diseases that might impair how much chemotherapy you give, although comorbidities in breast cancer patients tend to be a lot lower than in lung and head and neck patients. We also looked at advanced disease. This is about that controlling versus curing, and we found that breast cancer in particular tends to be a series of treatments. You may be given a treatment that controls the disease for a year, 18 months the first time, then cancer starts growing, you get another treatment, maybe you get 6 to 12 months of control, then another treatment, maybe 6 months of control, and so on. And we're giving up to sort of 6 to 8 treatments. Our concept as medical oncologists, we give everybody with breast cancer 10 lines of treatment, but actually when we look, that doesn't turn out to be the reality. We remember our successes better than our failures, and also our successes are coming for a long time to see us, and our failures sadly not so much. When we look at people getting 3 or more treatments, and I'm saying there's maybe a dozen available, it's only 16% in Aboriginal people compared to a bit over twice as many in non-Aboriginal people. So, and I did, looking through the data last night, see a high rate of declining in remote Aboriginal patients for this population. So if we can make treatment more acceptable, more accessible, then we might be able to improve that rate. And the average for people with advanced breast cancer was a bit under 2 treatments on average compared to 2.5 in non-Aboriginal people. And this led to about a doubling of survival in non-Aboriginal people with metastatic breast cancer, up to about 4 years compared to only 2 years average survival in Aboriginal people with advanced disease. Coming to targeted treatment, and breast cancer, as you many will know, comes in a series of types with different behaviours and different targets. And this is the non-Aboriginal patients in our group. The blue section is your lowest risk cancers. They tend to be estrogen sensitive, slow growing and easy to cure. And about 2/3 of the general population here. Compared to the nasty ER positive cancers, estrogen sensitive cancers, harder to cure, often need chemo. Luminal Bs, they're called, in orange. Triple negative, everybody knows the worst kind of cancer getting these days. And previously the worst, they're not quite so bad now, is the HER2 ones in grey. When we looked at the Aboriginal population, we saw about a 20% less people getting the easiest to cure cancer. And that shifted to the more aggressive estrogen receptor positive cancers in orange, the luminal Bs, needing chemotherapy as well. And also a doubling of the HER2 positive patients that need a lot of targeted treatment. So certainly anti-estrogens are still an important part for both populations. So and that's one of the biggest contributors to cure for breast cancer patients. So how did they look in breast cancer patients? And we saw a pretty good acceptance rate. It was just below 90 compared to just above 90% in Aboriginal and non-Aboriginal people. We found, though, that medical oncologists weren't doing such a good job with the Aboriginal population. In younger women, you usually get half of a tamoxifen and half of another anti-estrogen. The best, it's called a switch strategy, and that's the best treatment. We saw in younger women where it might be appropriate, only 1/3 of Aboriginal women got this switching, whereas over 80% of non-Aboriginal women got this treatment. And that's something where you need continual follow-up. We switch after about 2 or 3 years. And if you're not being followed up very regularly or at all, then this just doesn't happen. And that's certainly something we can potentially address. This was one of the big surprises as well. We found that Aboriginal women with the same drug got double the number of severe side effects with anti-estrogens, and this probably speaks to differences in the genetics handling anti-estrogen drugs. It might mean that actually different anti-estrogens are the best drug to choose in an Aboriginal lady compared to in a non-Aboriginal lady. And Katie and Aisha, I know postdoctoral researchers working with us, are looking at the genes in Aboriginal and non-Aboriginal people, how they handle drugs, how they affect side effects and benefits. And finally, with more side effects, as you might expect, less people get to the 5-year kind of goal of the standard anti-estrogen period, with 30 versus 10% not making that. And that can have, if you don't get 5 years of anti-estrogen drug, that made about a 10% difference to your survival chances with these cancers. So definitely likely contributor. Turning to targeted treatment in lung cancer. This was lung cancer when I was a lad, as a registrar. It was kind of non-small cell and small cell. I already showed you the graphs for those. And non-small cell is divided into a glandular type and a skin-like type of lung cancer. And that was it. That's all I had to learn. My registrars, it's got a bit more complicated. Everything's got a lot more complicated for my registrars. I had to know about 7 drugs, and they have to know about 700 now. So being an oncology trainee, there wasn't much to learn. It was handy, and I've just been able to learn it bit by bit, thankfully. All of this isn't necessarily relevant, but if you look at somebody who's had lung cancer and their biopsy report or their surgery report, you'll see all of these things measured. But there are a couple that we're now targeting with drugs, EGFR and ALK. And this is in published Australian population, 27% of the population had EGFR mutation. And this is a gene that's broken within these lung cancer cells. It tends to be in non-smokers quite frequently. And these people can have blockers to target that broken protein due to the damaged gene. And this is the control rates for a blocker compared to chemotherapy in those patients, about 3 times longer control. And I've got patients who are on these treatments for over 5 years with no return of their advanced cancer so far. And similarly, ALK, a less common one, but 8% of the general Australian population, again, 2 or 3 times longer control. And I have a lady who's now 7. She was originally on the first trial of crizotinib, the first drug, one of these cancers, and she's still on it 7 years later. And I reckon her survival with chemotherapy in about 6 months. What about the Aboriginal population, though? And we've looked at the reported results, and we see that they have 3 times less of these good prognosis, easier to treat cancers. 9% in the Aboriginal population compared to 27% with EGFR, and 3 versus 8% in the ALK group. There are, and we did notice, though, a bigger number of frequency of this KRAS mutation. It tends to be more common in smoking-related tumors, and we have got trials targeting that. So maybe we will have some targeted drugs that are better targeted at Aboriginal people with cancer. So this we have now, and that's where Aboriginal people are somewhat disadvantaged, but hopefully some of these trials will be positive. We'll be able to improve things in the future. And finally, immunotherapy. We say that's an expanding type of treatment. We're giving more and more. It costs about $250,000 per person per year. So it's a very expensive treatment. It shows how good it is because the government funds that for the public population. This is just to give you a snapshot of what it can do in a lung cancer. If you've got advanced lung cancer, 5-year survivors, if you get chemotherapy of 5% compared to 30% with immunotherapy. And looking at people who at 5 years have both got control and their cancer hasn't come back, and these people are likely cured, it's not spectacular, but it's 13% compared to 0 with chemotherapy, and which is about 1 in 6, and that's certainly better than 0. In melanoma, that figure is 50% people fully controlled at 5 years, in fact at 10 years now, with no return of their cancer, likely cured. So melanoma, even higher results. So it's about 1 in 6% people may benefit, but when we look at the signals that can predict that immunotherapy work, we haven't yet got results from Aboriginal people seeing how well immunotherapy works, how often. The 2 things we look at, the target protein of immunotherapy is called programmed F1. So we look for the deep brown staining in tumors, and if it's there, then immunotherapy is much more likely to work. We also look at the actual immune cells that are going to do the killing if we use immunotherapy, the lymphocytes, and the top one's got lots of little dark dots compared to the bottom one with a lot of pink collagen, and that shows a tumor that's got lots of a high lymphocyte infiltrate compared to low. And when we look at lung cancer patients and breast cancer patients, the non-Aboriginal patients doing those tests, looking at possible immunotherapy sensitivity, it's about 30% in lung cancer. It's only 10% in breast cancer, in hormone-sensitive breast cancer. When we look in Aboriginal population, it's almost doubled in the lung cancer population at almost a half, and it's 2.5 times higher in Aboriginal breast cancer patients. So it may well be that even though they don't get so much benefit from targeted treatments, expanding immunotherapy, particularly into breast cancer for Aboriginal people, might be very beneficial. So just to summarize that sort of story so far in the cancers we've been studying, breast cancer, we've seen more aggressive cancer types. We've seen higher stage. We've seen more immune cells, and they can be averse until you give immunotherapy. We see more vitamin D deficiency, more hormonal side effects, and less people completing treatment, less intensive chemotherapy, and less therapy in later cancers, all of which will contribute to poor survival. Head and neck cancer, we've seen the same sites affected. So we did look at whether the part of the head and neck was affected by in Aboriginal people was different. It was not. We saw more smoking, though, and less virally caused tumours. We saw that higher stage, but the delay was not an issue, the same in breast cancer. We saw less people accept curative treatment, and we have addressed some barriers there, including concern over side effects and time away from home. In lung cancer, we saw the basic types were very similar in frequency. We saw poor survival for the earliest, most curable cancers, though, and we need to look closely at that. Later stages had similar survival, however, though very poor survivors across the board. Smoking was at close to 100%, and therefore targeted mutations are higher, but immunogenicity and possibly therefore immunotherapy benefits are lower. Just to finally wrap up with ongoing work, we've talked about bowel cancer we've not yet looked at, and the plan for bowel cancer is look at about the last 10 years or so of bowel cancer patients. We'll be looking at diagnosis, looking at delays, whether there's delays to seeing a doctor, getting tests, whether those tests happen quickly. We'll be looking at a stage, whether the cancers are bigger when they're found, the lymph nodes affected, which is very important, and whether the cancer spread further. We'll be looking at whether the site in the bowel is the same, because different sites in the bowel can have different biologies that affect treatment. We also look at the type of cell in those bowel cancers, and we'll be looking at the genes that predict for bowel cancer risk involved in DNA repair we already talked about in cancer risk. We'll then be looking at the cancer biology, whether the drug handling genes that we talked about, those genes that are present in our normal bodies that define whether our drugs work and whether we get side effects from them are different. We'll be also looking at immune cell numbers in these cancers, as we have with breast and head and neck and lung cancer, sorry. And then finally, we're looking at treatment, whether people got radiotherapy and completed it, what the side effects were for rectal cancers, how intensivity chemo was used, as there are 2 intensives of chemo generally for bowel cancer, and whether targeted treatments were properly used as well. And once we've studied 3 cancers and also studying 4 cancers, the question is, what do you do with all this information? We're finding all kinds of different things that are different, may lead to us changing treatment, prioritizing treatments, looking to detect things earlier and so on. And the strategy is to identify Aboriginal people that get breast cancer through PathWest that diagnoses about 90% of Aboriginal cancers, and then work with their local treatment teams to have a multidisciplinary team discussion of each Aboriginal person that's diagnosed with cancer. And what that MDT process would add is to better individualize treatment for each Aboriginal person, thinking about mutations, biology, chemointensivity, side effects of anti-estrogens, and so on. And deliver culturally focused information. As there's nice preventative information, we need to work harder on culturally appropriate treatment information, I think. Refer to regional and remote services, as we've developed some of those, which I'll show in a sec. Provide care plans and survivorship plans for patients, because a big factor that a lot of Aboriginal patients and their families said was, it was fine at the hospital. Once we got home, we had no idea what we were supposed to be doing, who to ask, and so on. And so certainly provide care plans, survivorship plans, so people know more what they're supposed to be doing. Refer for comorbidity optimization, meaning dealing with other diseases, particularly in lung and head and neck cancer. And also finally integrating knowledge of bush and traditional medicine, and we have pharmacists who's interested in that. Once our MDT process is done with a plan, this is lung cancer patients across the state. The red dots are Indigenous people or a group of Indigenous people with lung cancer. And this, up to the beginning of 2020, was where you could have chemo, and Geraldton was about as far north as it gets. And so we now have set up through Fiona Stanley 3 sites in Narrogin, Karratha and Broome of a tele-video chemotherapy process where a medical oncologist and pharmacist video link with a patient, a chemotherapy nurse, and a local doctor to check people over before chemo and give chemo locally. And we've treated about 2,500 patients with chemotherapy, of whom about 20% are Indigenous, about 500. Something like sort of 2 days travel close to home. So those are our video chemotherapy clinics. And then the final aspect we want to add is talking about dealing with side effects, talking about information and lifestyle and what to do once you've got home after your cancer, a home tele follow-up clinic to help people deal with the side effects of the drugs, maybe switch them to the right drugs if they have a better switch strategy and so on. And then we're going to be recording it to observe our results and see if we're improving things and where further work is needed. And to obviously Indigenous consultation and culturally appropriate sort of guidance for all this is very important. And Katie in particular and Lisa have been working very hard on putting together a statewide Aboriginal cancer advisory panel. For each of these other previous projects, we had specific Indigenous people with a lived history of the disease. And Leanne's driven a lot of the help there as well. But this panel, we hope, will be available to anybody who's looking at doing Aboriginal research in any disease of the cancer with the initial focus, because the approvals process and actually finding people who can advise you on your project is hard otherwise. And this would involve representatives from the major health services, East, North and South. It would involve WACs and local treatment centres that have high Aboriginal populations. It would involve the central health organisations like Aboriginal Health Council WA, WAHEC, that's the Central Ethics Committee for Aboriginal Projects, and Cancer Council, as well as tumour-specific representatives to bring in biology and treatment information. So that was, that's it, but I just wanted to, I mentioned there's a good news aspect to the talk, and I've got 3 slides just on that. We've actually found when we looked at our breast cancer results, we looked at before and after 2010, we've actually seen that the gap is now narrowing, and this is non-Aboriginal patients. The red line is before 2010, the green line is after 2010, and no difference with a 92% 10-year survival, pretty good. When we looked at the Aboriginal patients, however, pre-2010's orange line, 77% 10-year survival, and it's risen to 85% in the second half, and that's the reduction in the gap there. And just to graphically illustrate that, 2010 we had a 15% survival gap to equivalent survivals, and by 2016 it had dropped to 7%, so better than halved. We're just starting to work on why that might be, because if we can work out how we've halved a gap, if it's been anything that service provision and other aspects of care have done, then big to know what that is. So far I've looked at whether there's a high rate of breast screen, because that tends to lead to lower stage and better early treatment. Not really. I saw a 1.5% difference in people getting screened, but that's not just quite the same as curing their cancers. Similar jump in or small increase in the non-Aboriginal population. The cancers weren't of lower stage. They've not got smaller, so it's not that. So we're not treating easier cancers. And there weren't less aggressive biology subtypes. If anything, the biology subtypes in both groups are slightly more aggressive, possibly due to the obesity increases. Better treatment offered and more treatment completed, we suspect, seems to be the most obvious thing it might be. It'd be nice if it was that, as we've been working hard on that, but I'm just starting to work on that data. Lisa did send me the data yesterday, but I didn't get to it, unfortunately. So, and so hopefully maybe next year we might be able to both know what it is and start to apply that to other cancers if it is indeed an improvement in services or other aspects of care. So to summarize, breast cancer incidence is lower in Aboriginal women with lower genetic risk and breast density possible causes. However, mortality is higher, driven by higher stage, more aggressive types, more immune cells that can be harmful unless you give immunotherapy and low vitamin D. Less intense chemo and more hormone side effects and less advanced cancer treatments add to the breast cancer survival problems. Head and neck cancer mortality equally is a lot higher, and more smoking-related cancers that have a worse outlook and also declining curative therapy will be partial contributors. Lung cancer mortality is highest in the early cancers. More smoking-related cancers are seen, and this leads to less potential for targeted treatment, but more promise from immunotherapy. And we're designing some statewide services to try and use what we've found and optimize care closer to home as possible. And hopefully the gap is closing. And just to acknowledge some of the many people involved, just to particularly point to Katie, who's in the audience, who's doing a lot of the biology and Aboriginal input work. Lisa, who's been with me for over a decade doing this in the middle, and also Leanne Pilkington, who's a Noongar lady who's been working alongside me for 17 years on this through all the cancers, a powerhouse of driving Aboriginal cancer care across the state. Thank you for your attention.
And for the wonderful talk. We're going to take questions first. I may have missed this, but is there any incidence on sort of onset of cancer being earlier or later? So I wasn't quite sure some of them occur later or earlier, but as well. The second question is, there is, from my understanding, a huge diversity of genetics within the Aboriginal community. Any sort of groups being sort of have some benefits and something we could possibly learn of that with certain genetic backgrounds?
So the first question, by coming on early, do you mean at a younger age, of the cancers at an earlier age? The answer to that appears to be no, not particularly. The Aboriginal population as a whole is younger, but we've age matched within that population. That should allow us to compensate. We did have a look because breast cancer, in particular in younger women, has a worse prognosis than older women for the same cancer. So that was an important thing to exclude. We did not see a difference. You're certainly right about that, you know, self-identifying as Aboriginal. That's a very multifaceted population with several groups that have different ancestries, and also some people are fully Aboriginal ancestry and some people only partially, which would affect the genetic mix, because you don't know, unless you do very detailed tests, where a particular gene came from. So because we have like 269 breast cancers in total diagnosed across the state, not enough numbers to judge that. One thing can say, we've got collaborators in Northern Territory, and they've seen this difference in, they've seen pretty much the identical difference in types of breast cancer. They see more HER2 positive breast cancers and more of the more aggressive estrogen receptor positive ones. But in Victoria, that wasn't seen by collaborators Shireen Loy and Aris Bergen there. And so whether that might speak to genetics being somewhat different. In terms of risk genes, we only have 2 Aboriginal families with a risk gene, BRCA2, in both cases. Let's say 6 times less than the non-Aboriginal population. We don't know actually what the inheritance route of that gene was from. It might not even have been an Aboriginal relative. So it could be 0, we don't know.
You mentioned that there's a lower rate of breast cancer in the population, and given that rate of risk of breast cancer increases with age, it's called a 1%.
Yeah, thanks for the question. Obviously, we're age matched, so we have each Aboriginal population is matched to, in the breast cancer case, 3 women of the same age with breast cancer. So if we looked at the whole population, we know the mortality difference is 30% within our age and remoteness matched population. Age should be compensated for, but it would certainly, I would anticipate, being as you say, the life expectancy of Aboriginal people, unfortunately, is not as high in general. Less people will be getting into that high risk of breast cancer. So I would anticipate, if we looked at the entire population, which we haven't done other than very generally, we would see if anything, a bigger difference. There was a second aspect to the question. Sorry, could you? I think I was okay. George.
Andy, thanks very much. Very informative talk. The issue of remoteness is large in your presentation.
Yeah.
You indicated that mammogram was reimbursed, and an explanation was remoteness. With a lot of data being presented, have they been also been matched in terms of remoteness? You know, you've got some survival figures and so on.
Yeah. So, yeah, well, so we remoteness matched. So remoteness is sort of the whole population, more or less out of the equation, though it's not entirely. When we try and remoteness match 3 times as many Aboriginal, non-Aboriginal people as Aboriginal people with breast cancer, we didn't have enough women who were very remote with breast cancer. So it sort of topped, if you like, with the reasonably remote rather than very remote population. So it wasn't perfect matching. When we look at the breast screening, interestingly, in breast screening, regional and remote populations as a whole, actually screening rates are a bit higher, and we suspect it's that thing that I've only been to one Aussie Rules game, and that was when I came for an interview for my first Australian job, and I thought I might not be coming back to Australia, might not get the job, so I went to an Aussie Rules game and quite enjoyed it, but I've not been back to another one because it's always there. And I think when the mammogram van, to bring it to the point, is only there for a set period of time, people know it's a finite time, they'll be gone. Whereas when you can always go for a mammogram, you never do. So we actually, the rates are slightly higher in the regional remote population generally, and they are about the same for regional and remote compared to metro Aboriginal people. So remoteness doesn't affect things so much, and it's both populations that do have a lower screening rate. When we look at remoteness and survival, it's quite interesting when we've compensated before. When we actually study the remoteness groups and its interaction with Aboriginal status, we see that remoteness far more affects the non-Aboriginal population. The biggest gap is in metro populations, because the metro breast cancer patients do significantly better than the regional and remote breast cancer populations, non-Indigenous people, whereas when you look at Indigenous people, they don't really seem to get a remoteness disadvantage. They do similarly in metro as in remote. So remoteness affects non-Aboriginal people and not Aboriginal people from our figures. And the remote non-Aboriginal people join the poor outcomes of the remote Aboriginal people. So yeah, there's no doubt lessons for service and information there. Yeah.
There was the risk factor of breast density, high breast density, risk factor for developing breast cancer. It also creates results to treatment.
Yeah, that's a good question. We just had a paper accepted yesterday, actually, on that question. Not in Aboriginal people, but we looked at, we've got a population of breast cancer patients where we have mammographic density measured by Jennifer, the queen of breast density, as I mentioned earlier. And we then looked at the chemotherapy shrinkage and actually survivals, and we saw that it was a little bit complex. We saw that in non-obese women, breast density didn't affect outcomes. The pathological complete response, which was a complete disappearance of the cancer, was about 30% if you had high breast density or low breast density. If you're obese, however, with low breast density, the complete disappearance of cancer was 30%. If you're obese with high breast density, it was 0. None of the cancers completely disappeared. So it appears if you've got high density tissue in an environment, potentially of growth factors and high hormone levels of obesity, then you get poor response. And we saw much poorer survivals as well. There was a 10% worse outcome as well. So in short, with a high sort of the obese population, both Aboriginal and non-Aboriginal, yes, is the shorter answer.
Definitely. I guess there's been some sort of discussion around the age of cancer onset, and I guess most of the data is really anecdotal rather than specific data. We particularly heard about it in bowel cancer and also head and neck cancer.
Yeah.
But seeing a similar sort of thing happening.
Yeah, it was a good question. Obviously, I mean, colorectal cancer in particular has been flagged as getting younger and younger. We haven't got our colorectal cancer data as yet. Obviously, we're coming up to that. Breast cancer, we skewed the age population somewhat by a matching, but we didn't see between the two cohorts a difference in the mean age of onset or the groups that were young. And we do have a particular focus on younger women as they do have worse outcome. So we didn't see that occur in breast cancer, though there hasn't been the same shift in breast cancer. Head and neck cancer, we haven't looked actually, to be honest, so maybe we're going to have a look So bowel cancer, we're interested to look. Breast cancer, we saw no difference. In neck cancer, we can look, but haven't.
So much, and it was a wonderful talk, and yeah, thank you.
Thank you.